So let's take just a moment then and switch back to you, Brian. I know you've been working with the Zero Suicide Initiative for some years. Could you walk our audience through exactly what Zero Suicide is?
Yeah, absolutely. So zero suicide is actually a model. And what it consists of are all of the different treatments, interventions, and approaches that we've been talking about so far. It's not a singular treatment. It's the idea that each of these individual treatments and interventions by themselves have shown the ability to reduce suicidal ideation, suicidal behavior, and that the power really is in bundling all of those together. And that on a population level, we could have quite a bit of impact by bundling these things together. So at Henry Ford, I work at Henry Ford, I'm great fortune of doing that, and we've been able to bundle a lot of these interventions together over the years, and we, after doing that, saw about an 80%, almost an 80% reduction in our suicide mortality rate for our behavioral health patients. We've seen some of these same decreases for several other organizations who have begun to implement this bundle of suicide prevention strategies and treatments. So it starts with the idea that in order to start the process, we have to identify people who are at risk. We have to engage them in treatment. That means putting together a care management plan, engaging them in care, and getting them on the right care pathway based on their level of risk. Entering them in suicide-specific treatment, not just behavioral health treatment or mental health treatment, but treatment like Dave and Christine talked about earlier that has to be targeted towards suicide-specific risk factors and towards that suicidal ideation and behavior itself. And then also to connect people during transitions of care. In the United States, where we lose people so much is when they move between settings, between doctors, between appointments with the same doctor. There's these long periods of wait where people fall through the cracks. And we've, in the past, always often blamed the patient for that happening. But the reality is that illness itself causes people to not be able to engage in treatment. It blocks them from doing the things that you and I think are normal behaviors, going to see your doctor. But that illness stops you from doing those things. So what we've always done is say, well, they didn't show up. Well, this is the idea that we really need to engage them and bring them in across the treatment pathway. So the important thing to know in this model is that it doesn't make sense for us to implement really high intensity treatments for every single person in the world. Christine mentioned that the highest risk period is right after discharge from the hospital. So people in that state, when they're just being discharged from the hospital, are at the highest risk period, which means we have the opportunity to match them with the highest intensity levels of treatment. The good thing about that is that most people who die by suicide don't have that experience. That's the smallest number, the smallest group of people, even though those people are at the very highest risk. So it makes sense to match people at the highest risk level with the most intense treatment approaches. The most people who die by suicide or attempt suicide never ever get into behavioral health. In fact, they're out in the community, they're going to their primary care provider and or general medical specialists. And in that setting, most people are not at risk. That's why we need low intensity approaches to identify people who are at risk, do things like safety planning, which are short interventions and can start the process of connecting people into more intense treatment once we identify risk and start the pathway. So this is an approach, zero suicide, that covers an entire health system, that can connect people from the very beginning where they're not even identified as being at risk, through the entire process of getting suicide-specific treatment and keeping people engaged in that treatment over time.
Great. So essentially a framework, you're creating safety nets and customizing. Some people need a larger safety net, some people maybe need a very small one.
That's right.
So being able to customize. Thank you all so much for your thoughts on these evidence-based strategies. We know that we have some things that have shown clinical utilization and some efficacy. What about the future? Let's shift gears now and talk a little bit about what's on the horizon and what the future may hold for suicide prevention strategies. And I know all of you are involved in some really important projects that I'm sure will get us closer to nailing down these numbers much lower than they are. So, Brian, since you were just talking about zero suicide, could you give us some ideas as to how the framework of the Zero Suicide Initiative is going to be optimized in the future?
Yeah, so absolutely. What we do know is that we have to identify people who are at risk and match the right treatments and pathway to them. But what we really need to figure out is who needs to be on which pathway. Some people are at greater risk and some people are at lower risk, and there are a variety of factors. Christine talked earlier in the webinar about all these different things, these confluence of things that come together that increase or decrease a person's risk for suicide. And what we have to do is figure out how all of those things work together to make somebody at greater or lesser risk, so that we can then figure out how to match the right treatment and pathway to people based on those risk levels. And so it's sort of a precision approach to treatment. And that would be sort of the next level of optimization. Now, we've done some of this at Henry Ford, where we've developed these risk strata and mapped people onto those risk strata. But I think there's a pretty significant opportunity with all of the data science and that's been coming out lately, and our ability to sort of use precision approaches to do significant matching of treatments to people. It may be that certain treatments work better for certain people that have certain history, certain environmental exposures, even certain genes or genetic factors. So we have to figure out that mix and what the right treatment is for each person based on that mix, and that's kind of on the horizon.
That's great, and you provided the perfect transition for me to ask Christine about what the future of medical, pharmaceutical, potentially biomarkers for suicide risk looks like.
Yes, that part of the science and suicide risk and prevention is really burgeoning, as are the treatment intervention development part that we've heard about on the psychosocial side. So some of the areas where the leading research are finding new results all the time, but are not quite yet ready for clinical prime time yet, are in the areas of really thinking about the differences in structure and function of the brain, so that neuroimaging is a tool that may be useful in the future and is certainly being utilized highly in research. This is one of the cutting edge areas right now. Another area that Brian alluded to are people's genes. Clearly, there is a genetic driver of suicide risk that may be even outside the genetic influence and the heritability of mental illness. So sort of separate risk factors that are carried in the genes for suicide. And so the science around being able to identify those who are at highest risk based on their genes is another potential for the future. Again, not quite ready yet for clinical application. And lastly, I'd say the other sort of category for biomarkers is looking at the basic biochemistry in a person's brain and body, and looking at some of the major neurotransmitters and utilizing what will probably be a combination of clinical interview and clinical examination, screening, and more traditional, what we think of right now, current suicide risk assessment, alongside a better way to utilize factors in the electronic health record, and then with some of these potential biomarkers that are coming to fruition hopefully soon, that we will be able to utilize all of that combination to have a bit more precision. There may be even other factors that we can measure that can influence those, the potential to really hone in more specifically. Right now, we don't have the ability to predict who is at short-term risk of attempting or dying by suicide. And And my editorial comment about that is that science is burgeoning, and we hope to make headway with regard to that, as well as short-term interventions that can be used for those people who are identified at short-term risk. But for now, I think there's a really important message that people hear, which is that in other fields of medicine, we don't let the lack of predictability of who will die and when of any health-related condition, from heart disease to cancer to other health conditions. And it doesn't stop anyone from, for example, cardiologists from going aggressively after the risk factors that they know drive up mortality due to heart disease. That's what we can do, from educating the public so that everyone kind of knows that if you have several relatives with heart disease or have died of a heart attack, you kind of know some of the basics around diet and smoking and exercise and stress management. Those are the things that we can employ right now across, public health, education approach, as well as in the clinical setting.
Right, that's a great point. And you've been talking about the complexity that is involved in suicidal ideation and behavior. So we're likely looking at a multifactorial approach that's going to be required no matter how much science and evidence that we have. So we've talked a little bit about the medicine. We've talked a little bit about zero suicide. What about technology? Where are we moving with technology, David?
We're moving a lot with technology. I would say, just to comment on a few points, that what we're really, I think, realizing is the power of technology to take things to another level. Brian alluded to this, but the idea of machine learning is a methodology for taking a lot of variables and through an algorithmic processing, developing pathways to optimally match a patient with the optimal treatment that's best suited to them. So you don't have a hammer and all the world's a nail. You have different interventions for different kinds of suicidal states. It's been a research area of ours for years, and for the field, looking at typologies, going all the way back to Emil Durkheim, looking at social integration. And we're now finding reliable methodologies for organizing people into different kinds of lanes or different kinds of types of suicidal states. Ecological momentary assessment, using a Fitbit or a cell phone to cue somebody to report how they're feeling, creates a lot of data points. And Matt Nock and his colleagues at Harvard, have identified 6 reliable ways that people ideate using ecological momentary assessment. Ron Kessler's work with machine learning, I think, is really sort of at the forefront of this precision medicine kind of idea that we would be able to perhaps route people into different tracks that would be optimal for their care. We've been granted by the NIMH 2 grants to develop an app on an iPad, basically, in the emergency department, where we know that patients oftentimes come and sit and wait 6, 8, 10, 12 hours, sometimes they're boarded overnight, before they see their doctor. And the idea of this was actually inspired by an intervention that was done at Boston University. A discharged nurse named Nurse Louise, and she was an avatar. And they did a randomized control trial between Nurse Louise and an actual discharged nurse, and found Nurse Louise got very good responses, and that patients like avatars, especially around shame-inducing topics. So we got a grant to develop sort of a parallel intervention in the emergency department, and did a proof of concept of that, which was featuring me as Dr. Dave. But the idea was to do an assessment and to create this opportunity for patients to hear other people's lived experience and how they survived their experience. You've got 6 to 8 hours to spend. We could do a modified version of CAM so that when the doctor does show up, he or she has a very detailed report that's been engaged, this level of engagement. And what we're currently working on in a second phase of this Small Business Innovation Research Grant is now an app. Dr. Dave is gone. We have now an app, and the app is multimodal. And so there's a phase where you can go and watch videos of burning fireplaces and aquariums and puppies, and learn mindfulness and learn coping strategies. Again, you have all this time to spend. Along the way, there'll be a modified CAMS assessment done by Jasper, which is like a little cartoon person, or a woman named Jazz, and this assessment will then lead to this report. And the idea here is that we might avert hospital stays. But in the course of doing this app, there would be a download to the patient's phone or to their computer of different things that they could do post-discharge, along with care and contact that would be automated post-discharge. So no one says the ED experience is not so bad, for especially mental health patients in particular. Many elope, many get very impatient, they get really dysregulated. So if we're able to capitalize on this window of opportunity and give them a meaningful experience with this app and help the doctor do his or her job better, decrease hospitalizations, and do things that are going to be effective post-discharge, then we're really talking about a different situation altogether. And because we have this time that's typically not well used, it's sort of the ripe opportunity to take advantage of that particular technology.
Right. Technology can do wonderful things. Next time we'll have you all send your avatars back for a subsequent webinar.
I already have one.
You'll have to bring him back.